So, genetics is a hot topic in cancer care, but understanding its role in acute myeloid leukemia can feel overwhelming. Your healthcare team relies on genetic testing to determine the best treatment options, predict responses, and create a plan tailored to you. If you ever wonder why genetic testing matters and how it impacts your AML care, this is the perfect opportunity to learn and feel empowered in your treatment journey. At the end of today's event, I'll provide my email address. If you have a topic you would like to see us cover, please reach out to me so we can get it in our schedule. So now let me take a moment to introduce our amazing speaker, an AML specialist, Dr. Harry Erba. I'm so excited to have him here with us. So for the people who doesn't know Dr. Erba, let me take a few moments to introduce him. So Dr. Erba is a professor of medicine in the Division of Hematologic Malignancies and the director of Leukemia Program at Duke University. He earned his Doctor of Medicine and Doctor of Philosophy in Biophysics from Stanford University and completed her internship residency and fellowship at Brigham and Women's Hospital. With over 25 years of experience as a clinical investigator in myeloid blood cancers, he has held key roles at the University of Michigan, University of Alabama, and Birmingham, and Duke University. Since 2012, Dr. Erba has served as chair of the Southwest Oncology Group Leukemia Committee and is a member of the National Cancer Institute Leukemia Setting Committee. He also co-leads the National Cancer Institute-sponsored MyeloMatch Precision Medicine Initiative, working to advance leukemia research and treatment. So now I see why I'm so excited to have him here. And now I turn the time over to you, Dr. Erba.
Okay. Thank you for that introduction. Mary Lou, can you hear me okay? Okay.
Yes, we can.
Great. Thank you all for joining. I'm going to not use slides today. When I'm talking to patients in clinic, I'm not using slides. And so I thought I would keep this very informal and leave plenty of time for questions afterwards. The use of genetic information has really been quite important in all of cancer medicine more recently. But AML actually has led the way. Back about 50 years ago in 1973 is when we had the first treatment that was found to lead to remissions in acute myeloid leukemia. And there was very little after that in terms of advances in treatment, and that treatment was very intensive chemotherapy, followed by often an allogeneic stem cell transplant, also known as a bone marrow transplant or a blood and marrow transplant. You know, doctors, we have 3 names or 4 names for the same thing just to confuse everybody. And then we give them abbreviations to make it more difficult. So I'll try to explain all these terms as I'm going through it. But, you know, back in the day when these treatments first came out, quite frankly, my predecessors, my mentors, they didn't have many options for clinical treatment of their patients. But they all had very active laboratories, which was really important in setting the stage for the advances that we now have for our patients with acute myeloid leukemia. They would take samples of their patients' bone marrow and blood back to the laboratory and look to define the genetic underpinnings of that disease. We know that all cancers are due to genetic changes that occur during a patient's lifetime in specific tissues, whether it be breast cancer, lung cancer, prostate cancer, colon, and in this case, acute myeloid leukemia. There are very specific genetic changes that will lead to those cancers forming. But when we start talking about genetic changes, it can be complicated. And I know as soon as I start talking about genetic changes with my patients in clinic, they are worried often about their children or their siblings, or did I get this from my parents? Okay, in most cases of AML and in most cases of cancer in general, the genetic changes that we can find are only in the cancer cells. which actually makes that change a change that can define if the cancer cell is still there after effective treatment. So that's the importance of it. Now, there are some genetic syndromes, genetic changes that can be inherited in families that can lead to a higher chance of various different cancers. Many of you may have heard of the BRCA genes, BRCA1 and 2, which increases the risk of breast and ovarian cancer. Okay. And there are genes like that in acute myeloid leukemia too that can be inherited in families and increase the risk of those cancers, such as TP53 or RUNX1 or CEBP alpha, just to name a few of them. But in general, most of the changes that I'm going to be talking to you about are things that are acquired during a patient's or during a person's lifetime. And there are different changes that we talk about in leukemia cells. The first things that were realized back in the 70s and 80s was that we can sometimes see changes in the chromosomes of the cancer cell. So all of our cells have 46 chromosomes, but in leukemia, quite frequently, in about half of the patients, there will be genetic changes in them. Loss of a chromosome, like monosomy 7, gain of a chromosome, like trisomy 8, loss of parts of chromosomes, or translocations and fusions. These were the first genetic changes that were used to define subsets of acute myeloid leukemia. And quite frankly, the only benefit to patients and to us is that it gave us some evidence, some information about the prognosis of the disease with various therapies. Not much else other than that. What changed was in the 1980s and mid-1980s and 1990s, the techniques to look at genetic changes in single genes were worked out. I was a PhD student back in the mid-1980s, and I can remember that's when PCR, polymerase chain reaction, was first developed. Before we had machines that could do this quickly, there was a graduate student like me moving samples along in water baths to get these samples analyzed and look at specific genes that we were interested in. And there are tens of thousands of genes. And what we learned from those studies is that we see genetic changes in people with cancer, in those cells, not in the normal cells. Let's focus on acute myeloid leukemia. We have learned that out of the tens of thousands of genes that are in all of our cells, there is actually a very small subset of those genes that are recurrently mutated. By recurrently mutated, what I mean is more than just in a one-off, one patient here or one patient there. These are mutations, genetic changes in genes that are frequently found in people with acute myeloid leukemia. And they fall into very different, distinct classes. They're not just any genes that are changed. The fascinating thing about these genetic changes is that they fall into classes that regulate the expression of genes that are necessary to turn an immature cell in the bone marrow that is called a blast. Blasts are normal cells that take that normal immature blast and allow it to grow up into all of the blood cells that we need to survive in this world. White cells to fight infection. We call them neutrophils or monocytes. Red cells that carry oxygen around the body by binding hemoglobin and delivering it to the tissues. Platelets, which clot our blood. And without these cells, then we can't survive. And the bone marrow throughout our lifetime has to continuously be making white cells, red cells, and platelets. A very common question I get from my patients with any kind of bone marrow failure, AML or aplastic anemia or MDS is, gee, I just got a transfusion. Now my counts are low again, several days later or a week later or a month later. Why is that happening? And the reason that happens is that the cells that are in our blood that are made in the bone marrow through development, differentiation from those blast cells, those cells have a finite lifespan. Red cells can last the longest, maybe about 3 to 4 months. White cells spend less than a day in the blood. They go into the tissues to fight infection. And then platelets, they might last somewhere around 7 days to 10 days in the blood, and they prevent vascular leaks, breaks in the vascular integrity so that you're not bleeding and bruising all the time. So if the bone marrow is not continuing to make those cells, the blood counts go down. That's why they go down. So then we come back to, well, in acute myeloid leukemia and other diseases like myelodysplastic syndrome, what are those genetic changes that are preventing the immature cells that are in our bone marrow called blasts from doing their job, growing up? And as I said, there are these mistakes that are occurring in the DNA during a patient's lifetime, during a person's lifetime, that leads to a block in the expression of genes necessary to produce a functional white cell, a functional red cell, a functional platelet. And those genes fall into very specific classes of genes that are involved in expression of genes important there. They also involve genes that cause proliferation. They are activating mutations in genes that cause the blast cells to start growing out of control. And you may have heard of some of these, like FLT3 or RAS or PTPN11 or KIT, to name a few. There are other mutations that occur in genes that suppress tumors in our body by keeping the DNA intact. TP53 is an example of those. And so out of the tens of thousands of genes, there are 50 to maybe 100 genes that are recurrently mutated. The first genome, the first DNA of a cancer cell that was completely sequenced was an AML cancer cell. And since then, now by next-gen sequencing, we could get this information back very quickly. So that's the information we're dealing with. Now, sometimes on these next-gen panels, next-generation sequencing panels, where we're looking at 50 different genes, you may find a gene that is found in familial syndromes, and your doctor will want to talk to you about your descendants and your parents about whether certain syndromes are running in your family. But that's pretty uncommon. Typically, what we're looking at are genetic changes that are characteristic of the AML. The next question I usually get is, why me? Why did this happen? Very often, we don't know in most cases. We do know that certain chemicals in the environment can lead to AML, like benzene exposure that's found in the petroleum industry, dry cleaning, rubber factories. So chemical exposure, radiation exposure, whether therapeutic or otherwise, like the survivors of people exposed at Chernobyl or Hiroshima and Nagasaki in World War II. We also know that, unfortunately, that patients with AML may have a prior history of another cancer requiring chemotherapy that damaged the DNA of those cells and caused another cancer like AML to show up. But in most patients, we don't know why these genetic changes are occurring. But if you stop and think about it for a second, it might not be that difficult to understand why this is happening. And it actually explains why acute myeloid leukemia is more common in older adults than younger adults and children. Of course, when we think of AML and acute leukemia, we pray for those children that are being treated at St. Jude's. We see them in commercials. And we think of acute leukemia as something that happens in children, which it does. But the incidence increases with advancing age. Now, the reason for this is the following. It's what I explained. The bone marrow has a finite, a small number of what we call stem cells that give rise to these blasts that then develop into blood, white cells, red cells, and platelets. Now, in order for your bone marrow to continue to make blood from the time you are a neonate, or actually in utero, a fetus, to the time you're 80s and 90s you're old, is that those stem cells have to replicate themselves so that some go on to make blood and some stay there as a reserve to make blood later in life. Well, every time one of those stem cells replicates itself, all of the DNA has to be perfectly replicated in those two cells. And guess what? Nothing's perfect. Not even the systems that God has made in us are perfect. Mistakes will happen. Those mistakes are often corrected by DNA repair enzymes, but not always. Now, some of those mistakes lead to the cell dying. You'll never know about it. Some of those mistakes have no consequence at all. You'll never know it's there. And some of those mistakes are in those genes that I told you about that are critical for the normal development of bone marrow cells into blood. And those are the ones that cause acute myeloid leukemia. As we are sitting here, whether you have AML or not, our bone marrow cells are mutating. I am now over the age of 65, and recent studies have shown that 10% of people over the age of 65 without cancer can be shown to have some of these genetic changes already in their bone marrow cells, in their blood cells, that may lead to developing myelodysplastic syndrome or acute myeloid leukemia later on in life. So in most people, we don't know why this happens. It's probably, we call it stochastic. It's by chance that these genetic changes occur, but they can be induced by chemotherapy, radiation, environmental exposure. They can be induced because you've inherited a syndrome that impairs DNA repair in your cells. And so these changes are more likely to occur. But for the majority of patients, we don't know why. Okay, so that was a nice little lesson on the genetics of cancer. And I'm talking to you, and the question has to be in your head, so what? Okay, is this just some information that leads to doctors writing papers that no one can understand, that they get grant money for, but it's not translating into something that I need? And here's where the advances have been made. This genetic information is vital now to the care of people with cancer in general, and specifically for acute myeloid leukemia. And there are several ways that this genetic information is used. Now, one of them that's been used the longest is the same as those chromosome abnormalities I told you we could see long ago and still detect by chromosome analysis or FISH analysis, for example, chromosome changes. Those can be prognostically important. We use them for risk stratification. Okay, well, that's not that useful, to be honest. We can use that information because some of these genetic changes may be cured, that those AMLs may be cured with standard chemotherapy, but many others may require allogeneic stem cell transplant, bone marrow transplants to cure the disease. So that's one way the disease, that risk stratification or that mutation analysis helps. But other than telling you what cards you've been dealt by the luck of these mutations that can occur in various different genes, there are much more important reasons for getting this information. Because now we use this information for two things. We can modify therapy for your benefit so that the treatments can be specifically targeted to some of the leukemias that we recognize. Unfortunately, not all of them yet, but that's why I'm not ready for retirement, even though I'm over the age of 65. We got a lot of work to do still. But what I've seen over my 25 plus years of being a practicing leukemia specialist is that since 2017, in the last 8 years, there have been a number of advances and drugs that have come into the clinic that have provided benefit for people with acute myeloid leukemia. And the list is growing. The studies that we are doing now, I can tell you, will lead to approval of drugs in the near future and expand the options for our patients. Now, one of the challenges we have in doing this is that we need to get this information back quickly, because unlike solid tumors, like prostate or colon or breast cancer, lung cancer, when those are diagnosed by a surgeon, right? And there's a major operation. And while the person is recovering from that major operation, might take weeks, and the doctors are considering, does that patient need more therapy? That genetic analysis can be done. And it could take several weeks to get that done. But we don't have that luxury of time in AML. AML leads to infections because the white count is low, bleeding complication because platelets are low. People need transfusions. The white count can shoot up very quickly, leading to trouble with breathing or trouble with cognition, trouble with thinking, leading to bleeding in the brain. I mean, it has to be controlled sometimes. And so often our patients with AML, when they are diagnosed by a primary care doctor or a specialist or in the emergency room, they're admitted to the hospital immediately. Why? Because we know that these complications can set in quickly. However, what we also know now is that we don't have to rush to start treatment. Now, that's not to say that we, send you home from the emergency room and hope you get an appointment with some blood specialist who knows something about leukemia in a month. That's not what it means. It means that with correct and appropriate best supportive care, we can await the genetic studies that will be done. PCR tests are typically done a little bit more quickly, within 3 to 7 days. Next-gen sequencing panels may take a couple of weeks. But we are really advocating, we meaning the leukemia physicians, are advocating patients to get that information, because I'm going to show you how it can direct treatment. And during that time, you can get transfusions. During that time, you can get antibiotics for infection. Even if the white count's going up, there are medications we can give to keep the white count under control. And in this case, the white cells aren't normal. The white cells are the leukemia cells. So to prevent them from getting to very high levels that cause strokes and trouble with bleeding in the brain or trouble with breathing and other organ dysfunction, we need to give other treatments. But we can do that as a temporizing measure while we are waiting for that information. Okay, so the next question is, that sounds okay, but do you really know that's safe? And this has been a big question. When I was training back around 1990 as a fellow, we were told you do not go to bed at night if there's a new leukemic admitted to the hospital without writing for what we call 7+3 chemotherapy. Like I said, it's the only thing we had back then. You wrote those orders. And in fact, back in those days, we weren't blessed with the infusion nurses we have now. And so it was your intern or your fellow that was actually injecting the chemotherapy in the middle of the night. That's what we were taught. You had to start treatment immediately. But like I said, we have learned in both younger and older patients that that's not necessary. And it doesn't impact on survival. Of course, assuming with appropriate best supportive care, transfusions, antibiotics, judicious use of drugs like hydroxyurea, you can control the disease waiting for those test results. And there are multiple studies out there showing that you can wait. Not only that, there are studies showing that by waiting and identifying a targeted therapy, you may actually be improving the survival of patients as opposed to just giving them the same old chemotherapy we've had, if an appropriate genetic change is found that can be targeted with one of the drugs we now have available. So it's safe to do this. Some of these markers we need to know quickly. For example, FLT3 is a gene that is mutated in 30% of people with acute myeloid leukemia. It gives a proliferative signal to the leukemia. In other words, the white count usually goes up very high. These are people who present ill from the disease, may have trouble breathing, severe fatigue, bleeding problems. And you need to get the disease under control. But we also know that that genetic change, when present, is underserved by the standard chemotherapies that we've been using since 1973. What we have learned in clinical trials is that by the addition of drugs that target FLT3, for example, midostaurin, also known as Rydapt, or quizartinib, also known as Vanflyta, by adding those drugs to chemotherapy, you can improve the survival of patients with leukemia, okay? Not just the response, the survival. This is critical. And when do you have to make that decision to add those drugs? Within 8 days of starting chemotherapy. So you need that information quickly. There are also chromosomal changes that we can identify at the time of diagnosis that might make the disease more susceptible to the addition of an antibody drug conjugate that we have had since 2000, actually the year 2000, then approved again in 2017, called gemtuzumab ozogamicin, or Mylotarg. When added to chemotherapy, it has been shown to improve the survival of people with certain chromosomal changes called core binding factor fusions, which are not that rare. 5% of older patients, 20% of younger patients have those. So we need that information. And so this information is leading to addition of drugs that are important immediately. Now, even in older patients, where we didn't make much headway until about 5 years ago, we're learning that those genomic changes, those mutations, can be very important. So in 2017, November, the FDA approved a combination of azacitidine and venetoclax for older patients over 75, or those who were unfit, too sick to get intensive chemotherapy, bad lungs, bad heart, whatever other medical problems they had. And they approved it because the addition of this drug venetoclax, called a BCL2 inhibitor, to a chemo drug called azacitidine, again, improved survival. And it works in all patients with acute myeloid leukemia to improve survival. However, and so you could consider it agnostic of mutation. In other words, you don't need to know the mutation. However, more recently, one mutation that occurs in about 5 to 10% of patients with AML, called IDH1, has been shown to benefit by the addition of another drug, ivosidenib, to that azacitidine. So we now have options, and I'm not going to explain to you that, like how I explained to the fellows or my colleagues, how we should position these different drugs. But the point is that this genomic information is immediately leading to the use of targeted therapies in younger and older patients with acute myeloid leukemia. And things are coming. So you heard that Kura Oncology is sponsoring this program today. Kura Oncology is one of at least 4 industry sponsors that are developing drugs that inhibit a protein called menin that is critically important in the pathogenesis or the progression of leukemia that's caused by a mutation called NPM1, or another mutation called KMT2A rearrangements. One of these drugs has already been approved for a subset of people with AML, and others are coming. And NPM1 mutations occur in about 30% of AML patients. And so we've seen these drugs are active as single agents. We are combining them with chemotherapy in clinical trials. And so being part of clinical trials is critically important to improving the outcomes of people with acute myeloid leukemia. How else do we use this data? Well, the data can be very important to tell us the depth of remission. If we know what mutations are there at the beginning, we can do tests that can look for that disease at very low levels and decide whether a person needs to go to a bone marrow transplant, or maybe they've been cured with intensive chemotherapy. There's more information on that subject, but we're using this MRD, these measurable residual disease assays, to help guide post-remission treatment. Should the person just get consolidation? Should they just continue with aza-ven? Or should we think about allogeneic stem cell transplant? And a little soundbite about that: just because you're over 70 does not mean that you're not a candidate for transplant. If you're otherwise healthy, you have a caregiver, and you have the ambition to potentially cure the disease, and you're told that transplant is the only potentially cure for what you have, that is an option. Do not let a doctor just say, oh, you're 71, you're 72, you're not a transplant candidate. Get another opinion from transplant doctors who do this every day. And so we can use this genetic information to follow the disease. And then finally, I will mention, if the disease does come back after initial therapy, the mutations that were present at the beginning may be gone, and other ones might be there. And so we may have a patient who doesn't have a FLT3 mutation, but at least 10% of the time when the disease relapses, it's there. And now you can target it with FDA-approved drugs that target FLT3, that in our trials, one of these has been shown to improve survival of people with relapse refractory FLT3 mutated AML, the drug's called gilteritinib. Or an IDH mutation may now be available, and we can think about using ivosidenib, olutasidenib for IDH1 mutated, or enasidenib for IDH2 mutated disease. And again, the menin inhibitors, one of which is already approved in the relapse refractory setting, and others are likely coming in the near future. So to pull this together, and I welcome your questions, what I hope that I've explained is these genetic changes that are occurring in the leukemia cells, they occur by chance, sometimes triggered by something else in a person's history that we will search for, sometimes because of a genetic syndrome that they've inherited. But these are just consequences of us living longer than we did back in caveman days, when we would die of infections when we were, or saber-toothed tigers or whatever it was, when we were 20 or 30 years old. And now people are living longer, and these genetic changes accumulate over time, and you get the right composition of them, boom, you have AML or prostate cancer or breast cancer or lung cancer. And we've identified these in AML. We can test for them at the time of diagnosis, at the time of relapse. And we strongly advocate for getting this PCR testing for specific genes like FLT3 or next-gen sequencing for this entire panel to help guide treatment options, not just risk stratification, but also treatment options at the time of diagnosis. And those treatment options may change based on a change in those mutations at the time of relapse. So we need to do them at that time as well, because now we have options to above just chemotherapy, and more are coming. So participation in clinical trials is really something that we are trying to encourage. The program that I am co-chair of, the MyeloMash program, is an NCI-funded precision medicine initiative in Canada and the United States, throughout these two countries, for people with newly diagnosed AML, where within 72 hours, the NCI is funding and next-gen sequencing and cytogenetic analysis. And what we are doing as clinicians, as clinical investigators, is we are developing clinical trials to test new therapies quickly in these targeted populations of patients. We can do this better than industry because we are testing the entire population. And so we will have studies for people with FLT3 or NPM1 or KMT2A rearranged, P53, and so on. Whereas drug companies, when they develop their drugs, may only be looking for people with an NPM1 mutation because that's the drug they have. And fortunately for us, because of the power that the NCI has given us to very quickly do this NGS sequencing, industry partners are working now hand in hand with the academic investigators and the NCI to develop these clinical trials. And so I think more is to come. We still have a lot of work to do, but I'm hopeful for the future for people with acute myeloid leukemia. And I'm not ready to stop this mission I've been on for almost 30 years, just when we're making some headway for people with this disease. So I'll stop, and I thank you all for tuning in and be glad to answer your questions.
Thank you. I think that was really enlightening. So thank you a lot. And it's time now for the discussion part of today's webinar. So if you have any questions, feel free to drop them in the chat. If you're watching on YouTube, you can do that too. And we will ask them live. In the meantime, we have a couple of questions that I received on my email.
Can I answer the one from Matt?
Yeah, go ahead.
Okay.
Let me read it for you.
Okay.
How we can get the genetic testing and what is the cost?
Right. So it would be very unusual now for a bone marrow sample that shows AML or myelodysplastic syndrome not to get the next generation sequencing done. The pathologists are doing this, and the reason they're doing it is the World Health Organization and an international consensus conference and the European Leukemia Network and the National Comprehensive Cancer Network. All of these bodies have not only strongly recommended the genetic testing, but they mandate it for the specific diagnosis of subtypes of AML. It's not just AML. One person's AML may be very different from another person's based on this genomic or genetic testing. So you typically shouldn't have to ask for it to be done. When you send the bone marrow, the pathologist should do it. Now, in our clinic, when I'm thinking about AML by looking at the peripheral blood smear, we specifically request the next-gen sequencing panel and the chromosome analysis. In terms of the cost, it's a great question. I can't speak for everyone's insurance carrier, but I could tell you that as time has gone on, it's become really very, very unlikely that a third-party carrier is not going to approve the genetic testing that is done at the time of diagnosis. Where you might run into trouble is, if it's done every time a bone marrow biopsy is done, yeah, that might raise some suspicion or eyebrows, and those might not be covered, especially if they're not needed for clinical practice. But at the time of diagnosis, at the time of relapse, it is recommended by these bodies, NCCN and ELN, to do this.
Awesome. We have a couple of questions. Are there any new treatment for NRAS or EZH2 mutations?
Yeah, great questions. Not yet. For RAS mutations, it's interesting. Some of these drugs are being developed in lung cancer for RAS mutations, but they have not made their way to leukemia yet or have shown any benefit yet. And so this is truly an unmet need. RAS mutations, especially in older people getting azacitidine venetoclax, have been associated with shorter response duration. The disease still can respond, but the duration of the response can be shorter in that situation. So clearly an unmet need. For EZH2, there are drugs in development, EZH2 inhibitors. Now, whether they're going to add any benefit is yet to be seen. There were drugs that were targeting EZH2 that didn't actually show benefit, but there are others that are still in development For example, there's one approved in lymphoma called valemetostat, which is a combination EZH1, EZH2 inhibitor that will be studied in AML. But right now, we don't have it.
Okay, she complemented her question below. She said, those were my mutations at diagnosis, age of 46, no medical condition. I'm almost a year out post transplant. Brother full match, some GVHD, but good so far.
Great.
Awesome. We have another one here. What is the future for TP53? I was lucky to be treated at Dana-Farber. However, many of the groups I am on seem not to be getting automatic bone marrow biopsy.
Are those two separate questions?
Or... no, she's just commenting like that was her experience.
Okay. So what's the future of P53? That's a deep sigh. This is a tough nut. We were very excited. We thought through clinical investigation, we had two classes of drugs that were going to show benefit in P53 mutated MDS and AML. One of them was called eprinetapopt, which kind of refolds the mutant P53. And the other one class of drugs were the CD47 antagonists or antibodies, blockers, like magrolimab. But unfortunately, randomized phase 3 studies did not show a benefit. And so, quite frankly, we are all searching for the next thing to evaluate in P53 mutated disease. You know, when patients have a P53 mutation, it's often the only mutation. But when you look at the chromosomes, they're all broken apart. This is part of the reason why it's called the guardian of the genome. It keeps the chromosomes and DNA intact. It suggests to me that in order to really benefit P53 mutated disease, we're going to need a completely different approach. If we can't fix the P53 protein, we're going to need a completely different approach from a targeted treatment to more of an immunologic one. Magrolimab and CD47 was our greatest hope, but it doesn't mean that other immunotherapies may not be effective. So this is a place where bispecific T cell engagers, chimeric antigen receptor T cells, CAR T cells are being developed. And honestly, some of our, I should say the best outcomes that we've seen in P53 mutated disease is after achieving a remission, undergoing stem cell transplant. And the reason why allogeneic stem cell transplant works in AML is not just that week of chemo and radiation before the infusion of the stem cells, it's the graft versus leukemia that's doing it, the new immune system being able to seek out those TP53 mutated AML blasts that might still be there and getting rid of them. So I'm foreseeing some immunotherapy is going to be needed.
Thank you. There's also a great question that I see a lot on Facebook, and they ask, for a healthy individual who had a parent, in this case a father, with high-risk MDS, which then transitioned to AML, is it recommended to get genetic testing?
It depends on the details of your dad. There is a hereditary condition in a DNA helicase, that's the name of the enzyme, mutations in this DNA helicase called DDX41. And mutations in DDX41 can be inherited, and they can lead to MDS and AML later in life, not earlier in life like many, but later in life. They tend to have a more slowly progressive pace. They often respond to azacitidine and venetoclax, but nonetheless, they are associated with myeloid cancers, bone marrow cancers like AML and MDS. And so it really depends on the genetics there. So there's a situation where if you have access to your father's medical information, that would be very helpful. Was there a P53 mutation that could be inherited? Was there a DDX41 or some other thing that could be inherited? RUNX1 has popped up as a question. RUNX1 mutations are associated with AML as well, typically not in much older patients, but it can be. So you want to make sure you don't have something inherited. Outside of that, this is a disease of advancing age, and so I wouldn't recommend mutational testing for that. It brings up a really important question. As I mentioned, for 10% of people over the age of 65, if you do next-gen sequencing of a blood sample, you may find genetic changes that are seen in AML or MDS in people who do not have those and may never have AML or MDS. And so I would caution people against getting next-gen sequencing if the blood counts are normal, because what we might find is clonal hematopoiesis. That's what we call it. And quite frankly, I think it might contribute to a worse quality of life because you feel like you have this other, another shoe is about to drop or something, and you're worried about this genetic change. I'm sorry, but sometimes I believe ignorance might be bliss, not knowing something. So if your blood counts are normal, I think I would leave it at that. And just with routine health maintenance, I do think it's important to get blood counts done with routine health maintenance. I have seen patients with AML present at the time of a routine health maintenance exam.
Thank you. Thank you. And I say thank you too. There's also this question. What does it mean when multiple mutations are present? Do they interact with each other? And how does that impact treatment decisions?
Right. So, one of the reasons why AML is so difficult to target with these targeted therapies, it hasn't been easy. Actually, let me give you an example of what has been easy. Maybe that's better. In acute promyelocytic leukemia in 1953, when it was first described, it was described by Hillstedt as the most rapidly fatal acute leukemia. People bled to death within days of the diagnosis. Now it's the most curable form of leukemia with all-trans retinoic acid, a vitamin A analog, and arsenic trioxide of all things, which has been in medicine for centuries. It actually works here. And so the cure rates are incredibly high. Why? Because the genetic event that causes that subtype of AML is a single genetic event called the PML-RAR alpha fusion. And that's what ATRA and arsenic target. They target that genetic event. There are no other genetic events before that. So by targeting that genetic event, the disease goes in remission. And in most people, it's not going to come back. Okay, chronic myeloid leukemia is another great example. BCR-ABL, we have targeted therapies for that, but it is the only genetic event at the time of chronic phase diagnosis. In AML, it is highly unusual to find only one genetic change, other than the example I gave of APL and maybe a few others. Usually there are more. In fact, the median or average number of mutations is 4. And the more mutations you have, unfortunately, the worse the prognosis of the disease. And getting older isn't good, for a lot of things other than wisdom and experience. And this is no exception. The older the patient with leukemia, the more likely they are to have multiple genetic changes in different genes in those classes of genes that I said could be mutated. And that gives some prognostic information. But the importance of that information is it also implies that by targeting just one of those mutations, you are not going to be able to make headway into the disease. Now, that's a bit of an oversimplification because, for example, NPM1 is a defining mutation in AML. And there can be other mutations that occur in the leukemia cells after that in a subset of the cancer cells. It might not be in all of them, like FLT3 or IDH. In fact, in the study of the drug, the menin inhibitor in NPM1 mutated disease, we have seen complete remissions of the disease, even though that drug is just targeting NPM1, the disease goes into a complete remission and the other mutations go away. Why? Because they were just in the cells that developed from the initial event of NPM1. So it might be possible to identify the initiating event and target it, but we need to, we're not at that stage yet in AML therapy where we can tell in an individual person which mutation came first and which one came later. But maybe someday we will be, and it will help us identify how to target the true driver of the leukemia. But to answer your question, your final question there, do they interact? Yes, they interact. We know that NPM1 is generally considered a favorable risk unless you have complex karyotype, unless you have secondary mutations. Some studies have shown that impacts on the prognosis of NPM1 mutated disease. In the study that I co-led for the approval of quizartinib, the FLT3 inhibitor, we have learned that the benefit of quizartinib with chemotherapy was most pronounced in patients who not only had FLT3 mutation, but also had the two other most common mutations, NPM1 and DNMT3A, all three of those. And so we are really at the infancy of trying to understand how these mutations interact with each other and respond to different treatments that we have.
Thank you. And I'm going to wrap up with the last two questions. So there's a question here from Pat. It says, where do we stand with RUNX1?
Yeah, another problem, right? RUNX1, just so you know what RUNX1 is, the other name for RUNX1 is the AML, it used to be called the AML1 gene, AML1. And it encodes a protein that is a transcription factor that's critically important in normal development of bone marrow cells. It's called the core binding factor alpha subunit. Core binding factor protein is the alpha subunit. That's what RUNX1 gene encodes. Critically important in normal gene expression. We don't have a target. It is clearly a target that we would like to be able to target. We don't have something yet, but I feel like that's going to be coming soon because I think we're gaining a lot of insights into what we call epigenetic modulation of gene expression. In other words, these mutations in transcription factors, the spliceosome, chromatin modifiers, all of these things that affect genes being turned on and off, I think we are at the forefront of developing drugs that can affect that. And a great example of that actually is the menin inhibitors, because that's exactly what they're targeting. They're targeting a scaffolding protein, menin, that's critically important in normal gene expression. So I think others are coming. The scientists are providing this information that'll be translated into drugs for people, but we're not there yet in many of these subtypes that this very learned audience has already come up with. RUNX1, P53, RAS mutations still have a lot of work to do.
Thank you. And I think this is a perfect question for a wrap up. They say, aside from signing up all the extra studies like I did after my stem cell transplant at Dana-Farber, what can AML patients do to help those in the future?
Well, I mean, you've already been through treatment. AML patients in general, being treated at centers that have clinical trials of novel therapies, I think is going to advance, the treatments for people with acute myeloid leukemia. That's number one. We all know that there are, without getting political, there are events occurring in this country that make us worry about grant funding for research. We need to be advocates for, people with cancer, and specifically AML, but other cancers. This research must go on. And right now, cuts are being done in a rather draconian way without really much thought about what's being cut and what should be left going. So advocate for the research dollars to continue. And then the last thing I'll say, and this is something I learned just now, what you heard at the beginning of this from HealthTree about how we are in academia, in industry, we are handcuffed by rules of disclosure, and consent in getting all of this data together. An organization like HealthTree that encourages you to share your health information so that researchers can then go and look at real world data on how patients with P53 or RUNX1 mutated AML do and what things might be working. I think that's just another piece of the puzzle that will help improve outcomes for people with leukemia.
Thank you. That's great. Yes. So I will just have a few slides for the wrap up. Thank you again, Dr. Erba. That was amazing. I think we all learned a lot today. Before I wrap up, I just wanted to remember everyone that once you just leave Zoom, you will be prompted to a survey. We appreciate a lot if you take just a few seconds to give your feedback. We love to create events that are important for everyone. So thank you for that. I also wanted to highlight a great resource for those looking to manage their nutrition with AML. So if you join to our website and you click on their community, and then all events, you will be able to see all our upcoming events on our past events. This event was hosted on January. Feel free to check it out. You can watch the recording. You can learn about how nutrition impacts AML, tips of managing appetite loss, nausea and fatigue, some myths and facts about diet and cancer. So I hope you like that. I just want to also remind you about a few of our upcoming events. We're planning on a great event about breaking down AML treatment, your roadmap after diagnosis. We also have a few other events in the planning process that Mary and I are very excited. So you need to stay tuned to our news letter to check when that will be. And again, thank you all for being here today, and don't forget to complete the survey before you go. As always, I would like to thank our sponsors with whom this would not have been possible. So thank you, Cura Oncology. And finally, I just want to say thank you all for helping us build our AML community. I added my email to this slide. Please do not hesitate to reach out to me just to say hello if you like the event or not, or there's anything you would like to learn more about. I appreciate you all, and I hope you have a great rest of your day. I hope to see each of you at another webinar soon. So thank you and goodbye.
Bye. Thank you. Oh, thank you.